Okay, I think we'll get started just for the sake of time. Hello, everyone. Hopefully you can hear me. My name is Nicole Cork. I'm the Senior Association Manager of iHEA Activities. Welcome to the webinar, Health Results-Based Financing at the World Bank. What have we learned so far about effects, equity, and spillovers? Hosted by the iHEA Financing for Universal Health Coverage Special Interest Group. Today's webinar will run for approximately 60 minutes and will be recorded and uploaded on our website afterwards. The presentation slides will also be loaded onto the website, so please don't worry if we move through them quickly or there's no need to take any notes. Before we begin the webinar, I just wanted to run through a couple of housekeeping items. If you experience any technical issues during today's webinar, please write them in the chat box at the bottom right of your screen, and I'm happy to assist. Everyone on the line has been muted except for the presenter in an effort to eliminate background noise. If you have any questions during the webinar, please use the chat box and we can address them by today's moderator, or Jeffrey will address them. We also ask everyone to keep their webcams turned off if they're having issues with them. And we'll be circulating a survey following the webinar to obtain any feedback, so please take a couple minutes to fill that out if you can. So thank you again, and I'll now hand it over to Virginia Wiseman, who's moderating today's webinar and the chair of our iHEA Financing for Universal Health Coverage Special Interest Group.
Nicole. Hi, everybody. My name, as you just heard, is Virginia Wiseman. I'm a health economist at the Kirby Institute in Sydney and also at London School of Hygiene and Tropical Medicine in the UK. We're very privileged to have Jeff Tanner with us today to kick off the webinar series for our special interest group. Jeff is a senior economist at the World Bank, where he's currently the Evaluation World Lead for the Global Financing Facility. In that capacity, he helps lead the Impact Evaluation Portfolio for the Health Results Innovation Trust Fund. Prior to those positions, he was lead economist at the Millennium Challenge Corporation for 5 countries and directed the Presidential Initiative for the Partnership for Growth in El Salvador. He's also worked as a policy analyst at RAND and was a member of the World Bank team responsible for the 2006 World Development Report on Equity. Jeff received his Master's in Development Economics from Harvard University and his PhD in Policy Analysis from the RAND Graduate School. So once again, thank you very much, Jeff, and over to you.
Great. Thank you so much, Virginia and Nicole, for the invitation. It's wonderful to be with all of you, especially on today, which is a UHC Day. So it's terrific to be able to talk about some of the issues around health coverage for populations, for equity, and for services. So I want to start by noting that the information and the data that I'm going to present today are around the Health Results Innovation Trust Fund, which is a trust fund set up by the UK and by NORAD to try to understand what the potential effects might be of results-based financing. It really was exploratory in nature. So there were a lot of pilots set up around, and those pilots were all paired with very rigorous impact evaluations. And it's that body of evidence that we will take to look at to see what the effects are. Now, the utility of just looking at the bank is that we have it improves the homogeneity of who the implementer is and how the implementation process works. Of course, the downside is that by not integrating results from non-bank projects, we might lose something of so there are some trade-offs there that we acknowledge right from the beginning. Let's see if I can get these slides to advance. Great. So just as an overview of what we'll do today, we'll have introducing the concept around results-based financing, the main effects that we find, the main population effects from these impact evaluations, and then we're going to explore some potential unintended consequences that often come up in the literature or people's concerns, and rightfully so, in terms of being exercising some caution about it. And then finally, we'll wrap up with some key lessons and implications based on the experience so far. So if your connection drops, these are the things that you should know, that you should take away. I'll note that this is 3 different presentations kind of smushed into one, sort of in honor of UHC Day. We're covering everything universally. So to that end, we'll move quickly, but these are the things that you should take away, and you should note these threads as we go. First, that results-based financing, as we've seen it, can indeed improve coverage and quality, but it does not always do so. It usually does, but it does not always do so. It is usually equity neutral in the sense that it doesn't tend to benefit one group over another group, unless there is some very hard explicit targeting in that. Also, RBF has had few instances where we can systematically see and robustly see instances of negative spillovers on other services. There are some, and we'll get into those in a minute, but there are very few. And last, RBF is a complex intervention, and its effectiveness is a function of implementation fidelity. So that doesn't mean that it cannot be applied in fragile settings. Indeed, it has been and has been done successfully. But the implementation fidelity is really sort of the key driver to seeing the effectiveness. We should note, though, that these conclusions are based on a body of evidence that is relatively new and will be growing in the coming years, tripling, in fact, in the years to come. And we will be subject to continued aggregation and meta-analysis as we get this additional information and these additional studies flow in. So going over the basics of results-based financing. It's a cash payment or non-monetary transfer made to national or a subnational government, a manager, a provider, a payer, or even a consumer of health services after predefined results have been attained and verified. RBF is most often used as an umbrella term, and we recognize that there is some discussion over the terminology here. But as we'll use it today, RBF encompasses various types of interventions that target beneficiaries, for example, with conditional cash transfers. That would be on a demand side. It can cover providers through performance-based financing, or country governments, for example, with the cash-on-delivery mechanisms. The type of RBF that we will be talking about mostly today, and indeed is most of the RBF existent in the Health Results Innovation Trust Fund portfolio, is supply-side RBF, where we are contracting usually they're contracts with governments, but the contracts extend from the governments to clinics or to clinicians, and that they are linking the payment to results through these contracts. The contracts also stipify an increased level of autonomy to allow these clinics or providers to use that additional money in ways that they see fit to buy the inputs and make the staffing arrangements that they think would be best to improve the level of health outcomes and outputs. Now, and including coverage and quality. Now, all of that is subject to a stringent verification mechanism. And it's that verification, as much as anything, that really distinguishes results-based financing from other types of just direct financing. So the HRITE portfolio, where are we learning? Well, there were 32 country pilot grants that the bank has made doing results-based financing. That covers results-based financing schemes where we have evaluations in 30 different countries. So some countries received more than one pilot grant. Of those 30 different evaluations, 24 are rigorous impact evaluations of an experimental design, like randomized controlled trial, or a quasi-experimental design, something like a differences in differences, or a match differences, or sometimes even a regression discontinuity. Where we stand right now, as of today, baseline data has been collected for all impact evaluations, and we have completed impact evaluation results from 7 countries. And it's those that we will discuss today: Afghanistan, Argentina, Cameroon, Democratic Republic of Congo, Rwanda, Zambia, and Zimbabwe. Those are all now currently publicly available, and you can go and you can look at the data for yourself. there are results from Kyrgyzstan and Nigeria that are early. We'll be presenting a few of those results around equity in particular, but the bulk of those results will be available soon, and will be quite interesting. So in terms of these completed impact evaluations, I've listed here the particular authors of all of these pieces. I am not the author of these pieces here. Rather, as Virginia noted, my role is to sort of collect and coordinate along this broad portfolio. So it's important to understand, though, what each of these results-based financing mechanisms is trying to do in each of the countries. And as we'll see, there's a significant degree of heterogeneity even within a supply-side RBF. So in Afghanistan, we have an NGO implemented pay-for-performance in primary care and hospitals. They have 5 services that they're focusing on. They use a balanced scorecard, and they capture different dimensions of quality. The comparator group, or the counterfactual, was business as usual. In Argentina, there are actually 2 studies, 2 slightly different variations of RBF. First, there is the insurance for maternal and child health to uninsured families based on a large social protection program, and pay for performance for 80 services, and the authors used administrative data to capture those. There is also a second study where there is a purposefully temporary increase in pay for performance for the early initiation of prenatal care. In Cameroon, we have a sort of a standard performance-based financing package for 6 services with a quantity and quality checklist, and we compare that to enhanced financing, or financing that's not linked to performance. There's no verification piece with it, and additional supervision and business as usual. So there's sort of a 2-by-2 comparison there. In the Haut-Katanga district of DRC, in that pilot, there's a pay for performance based on 7 primary services, 3 secondary services. The comparison group received funding based on staffing levels and composition. It was not a results-based financing scheme in the sense that there wasn't verification in the comparison. Rwanda, we have 2 impact evaluations on 2 different programs in that country. The first was a pilot provided. The first pilot was provided bonus payments for 14 services directly to health centers. The second provided demand-side in-kind incentives for perinatal care utilization using community health workers, and that combined with a demand-side community health worker cooperative performance payments. The comparison there was, again, business as usual. In Zambia, we have a standard PBF package for 9 services and a balanced scorecard to enhance financing, and uses just the pure comparison arm. And in Zimbabwe, we have contracting for health facilities, user fees are waived, and there are referral services for secondary levels, and the comparison there again was the so let's move on to the main effects. So we're going to look at coverage and utilization of services, quality of care, and human resources. These are covered in greater detail in a piece by my colleague, Ishani Kanpal, and you can look there for more details. So first, in Argentina, that first impact evaluation of the broader PBF saw an increase of just under 2 prenatal care visits and a 24.7% increase in tetanus vaccine coverage. The second impact evaluation, where of the large but temporary increases to providers, saw a 34% sustained increase in early initiation of prenatal care, even after that temporary increase went away. In Cameroon, we saw increases in coverage of child vaccination and maternal immunization, and improvements in the coverage of modern contraceptive prevalence. In Rwanda, that first IE, the more supply-side based IE, saw a 23% increase in institutional deliveries and 56% increase in preventive care for young kids. And the community PBF, with the demand-side incentives, increased antenatal care and postnatal care, but there was no effect on supply-side incentives. Perhaps not surprisingly, as that one was a demand-side incentive, a demand-side focused approach. In Zambia, we see institutional deliveries increased by 13 percentage points. Birth attendance increased by 10 percentage points. But the enhanced financing arm was even more effective in both of those, with a 17.5 percentage point increase and a 14.2 percentage point increase. Full vaccination coverage generally remained constant in RBF districts while decreasing in the other two arms. So this is one of the nice things about doing a good impact evaluation or a randomized controlled trial, is that we take care of all the other unobservable factors, and so the only difference, we can attribute then any differences between the treatment and control to the intervention that we have. Even in cases where the secular trend might have been decreasing in coverage rates, as in immunizations here in Zambia, we're still able to detect a preserving effect in RBF. In Zimbabwe, we see increases in skilled birth attendance by 14.7 percentage points and institutional delivery by 13.4 percentage points. In Afghanistan, we see no significant changes on any of the targeted indicators for coverage, and we'll get to quality in a moment. But in Katanga and the DRC, we saw improvements in preventative care, but no measurable impact on utilization. Now, in terms of quality of care, so that was coverage. For quality of care in Argentina, we see a 74% fall in hospital neonatal mortality in the larger facilities, but the second impact evaluation, the temporary increases, did not show an improvement in birth outcomes. In Afghanistan, we see more complete physical assessment and clinical counseling, and more time spent with clients. In Cameroon, we see better availability of necessary equipment for delivery, of neonatal care in particular, and more qualified workers were present on site when we did the rosters of who was actually there at the clinic. We also saw out-of-pocket expenditures decreasing. So in Katanga, in the DRC, we see process quality and patient satisfaction really didn't change much. And we should note that in the DRC RBF, there were some real challenges with implementation. It was not terribly well implemented, as we would have hoped it would be. And so because of that, it's not surprising that we don't see improvements in many aspects in the DRC. There, in fact, we saw that. So I noted earlier that that RBF is a very complex scheme, and if you don't get it right, it can go wrong. And in that case, we saw that the payments were actually not being made to many of the practitioners in the DRC, and so they were being asked to do more and being given less money. And so it's not surprising then that we see both patient satisfaction not changing, and as we'll see in a moment, negative changes to HR. In Rwanda, the first impact evaluation saw about a sixth of the standard deviation increase in quality of care for prenatal care, but there was no change in the demand side RBF in many dimensions of quality of care. Zambia saw completeness of antenatal care increasing, but no increases in testing or supplement provision. But we did see increases in time spent with patients. And finally, in Zimbabwe, we see a very large increase in the availability of equipment and improvement and many process measures around antenatal care. In human resources, specifically worker motivation, we don't see a change in Afghanistan or Rwanda, interestingly. And as I mentioned just a moment ago, we do see these large decreases in intrinsic motivation in the DRC. In Cameroon and in Zimbabwe, we see mixed evidence. So there are positive impacts on satisfaction with infrastructure and availability of equipment and supplies, but not an intrinsic or extrinsic job motivation or satisfaction. In Zimbabwe, we see satisfied staff increasing, not by a lot, but by a notable amount, but lower motivation, which is driven by the size of the incentives and the unit prices, which an interesting result for us. So it really does look like the size of incentive matters, not just incentivizing at all. And in Zambia, we see a significant exception to all this, where we see very, very large increases in health worker satisfaction, an increase of 8 percentage points. With many of these impact evaluations, we also paired them with complementary evaluations, qualitative evaluations, usually doing process tracing or another kind of process evaluation or focus groups. In those cases, it's useful to sort of share some of the results. So in those cases, we see that PBF enhanced fiscal decentralization and improved financial autonomy, at least in Zambia and Zimbabwe, where PBF facilities performed better than control facilities in terms of health facility governance and managerial autonomy. So the RBF districts there were more likely to allocate their facility budget according to their needs, for example. PBF credits tended to be invested in infrastructure, supplies, and equipment, and improved sanitation and hygiene. As a result, facilities appeared well kept to independent observers and were attractive to patients, as reported by patients. The verification visits led to greater transparency and accountability by promoting more accurate self-reported information systems, at least in Zambia, where that was measured. And in Zimbabwe, we see client reports of improvements in quality of care. Finally, we see health workers exerted more effort to attain results, and incentives were boosting their morale, particularly in Zambia. Okay, so we see that overall, in terms of coverage, PBF can improve coverage. But as today is UHC Day, we also want to understand some of the other dimensions of health coverage, not just service coverage, but also population coverage. So one of the questions that often comes up is, well, what about equity? Who is actually being served by this? And so in some work that I led, we tried to explore this question a bit more. To do that, we look at implications from 8 different countries: Argentina, Afghanistan, Cameroon, Kyrgyzstan, Nigeria, Rwanda, Zambia, and Zimbabwe, and 5 outcomes along the reproductive, maternal, and child health continuum of care. So we're looking at the same outcomes across these different countries. We're looking at modern contraceptive prevalence rates, antenatal care visits, skilled birth attendants, postnatal care visits, and immunizations for children. Now, we should note that we determined these outcomes that we were going to look at before we went into the data. So to minimize the possibility of data mining or multiple hypothesis issues, we did multiple hypothesis testing whenever required. Now, this of course depends on data availability. Not all outcome estimates are available or presented for all countries. So this is what it looks like. So in Zimbabwe, as an example, so we ran each country separately, and each one of these affects separately. So again, the overall population results here we have for these 5 outcomes. We also, in Zimbabwe, we were able to disaggregate an equity measure by education as well as by wealth. So the education measure here is whether they completed primary education or less, and the wealth measure is whether they were above or below the median on an asset index. And as we see, there is some positive movement in equity for skilled birth attendants, and I should note here that by equity we are meaning explicitly, does the bottom half of the population fare better than the top half of the population? We have other results elsewhere where we're looking specifically at the bottom half or the bottom 2 quintiles to see, do they benefit in a subgroup analysis. Those results are largely similar to what I'm going to present here. And this is sort of the overall, the meta slide for equity effects on health coverage. So again, we have the 5 outcomes on the left-hand side and the different countries across the top. You'll see that these results are characterized really by a lot of null results happening everywhere. Null and fairly small for the most part. Usually positive, even when null. And for those that are significant, we see that the statistically significant results tend to be positive or progressive, in the sense that the bottom half of the distribution, and this is all for wealth, or yes, for wealth I should note, the bottom half of the wealth distribution seems to be faring better than the top half when there is a difference. There are some exceptions, and it's important to note those exceptions. A couple of marginally significant exceptions in immunizations for Afghanistan and postnatal care for Kyrgyzstan, as well as an interesting result where in Cameroon, the bottom half of the distribution benefited less than the top half of the distribution for skilled birth attendants. So what do we see here with RBF and equity? First, there are very few cases where the impacts of RBF are exclusively pro-rich. That's from analysis that we don't show here. But we also see that there's really not a negative effect on healthcare equity. There are also, however, very few cases where PBF improves equity in being significantly and solely pro-poor. Zambia is the exception there. So as a first pass on this, and I want to over and over today just underscore the nascent nature of the results that we're getting, and that these things will change and will improve. And I hesitate from taking the results from any one particular country as representative of RBF everywhere, particularly where we have the coming luxury of so many different evaluations that we will see. But we see that as a first pass, PBF as a reform focusing on the supply side of healthcare seems to be equity neutral. However, the PBF programs themselves have often been targeted toward disadvantaged groups and areas. And so as we take this equity work forward, one of the things that we are looking at doing is comparing the populations that appear in the data with the populations and the distribution that exists in national surveys. So, for example, in the DHS or the mix. But we do know that even cases where there doesn't seem to be a difference between the rich and the poor, as in Argentina, that Argentine program was already expressly targeted through using a mechanism for the social protection program, was already expressly targeted at the poorer parts of the wealth distribution in Argentina anyway. So what we learn here is that within the target population, there seems to not be effects and expectation, but through targeting, we actually can improve outcomes. So the next question that we sometimes worry about with RBF in terms of unintended consequences is crowding out. And here, the concern is that, hey, if you're paying for some results, won't other part of the health service delivery mechanism suffer? And fortunately, we have an answer. That answer is maybe. So, and really, that's a function of the complex interactions with the health system. So don't get worried about the details of this graphic, but this is just to note that the health system, as we have sort of envisioned it within the HRITF team, is incredibly complex with various different layers. The core of it, you can see right there in the middle with health system, is these 6 different pillars of the system, including service delivery, human resources, financing, governance, medicines and commodities, and information. We know that RBF can have an effect on and can work through all of those, but doesn't necessarily have the same effect for everything. And it's going to interact with the health system in complex ways. And as a complex system, we can't always predict the ways in which that effect is going to happen. So fortunately, we can go back and rely on the impact evaluations where we can use reduced form results to understand the effects. We can also look at economic theory to try to give us some understanding of what might be going on here. So we're going to employ the production possibility frontier from producer theory. So as you'll all recall, the PPF is the theoretical limit at which for a given level of factors of production or inputs, you cannot produce more of any output without giving up some of a different output. So for RBF, we can think of that if you are productively efficient, so you are at that frontier, you cannot produce any more of your incentivized outcome without giving up some of the non-incentivized outcome. However, what happens? So in that case, again, there would be a negative effect if you were at the frontier. If we can think of this in terms of an extra marginal effect, where we're substituting time out of non-incentivized services, so coverage. So maybe we're incentivizing, we have incentivized antenatal care visits, but we have not incentivized iron tablets. We might worry that we have fewer iron tablets as an extra marginal effect. We might also be worried about an inframarginal effect, where we might be worried about substituting time out of the quality of incentivized services. So if we have institutional delivery as an incentivized service, are we substituting out, or are we paying a price on time spent with patients? However, if facilities are not already productively efficient, or they're not at the edge of the PPF, or if they're at point D there, then improving some parts of the system, as through results-based financing, may improve other parts as well. So we might go from D to A. So in that case, we can improve both the incentivized and the non-incentivized outcomes. At a minimum, we could see that there could be a neutral effect. That is, it could be possible to move from point D to C, where we're improving on the incentivized outcome, but not giving up anything in the non-incentivized outcome. Now, ultimately, this is an empirical question of whether or not we're at the frontier or not, and what the trade-offs might be. Fortunately, we have data from the Health Results Innovation Trust Fund, and so we can explore that data to try to get a sense of what the effect is on unintended consequences on unincentivized outcomes. So summarizing these from 4 countries, in Cameroon, we don't see negative effects on quality of antenatal care or on under 5 consultations, so completeness of service and advice provided. So those are more on the inframarginal effects. In Argentina, we do see a small negative spillover effect on prenatal care utilization of non-beneficiary populations. So this is another type of an extra marginal effect, but it's an extra marginal effect on coverage of population. So those who were not in the beneficiary population from the Social Protection Program saw a slight negative effect on prenatal care utilization. But we don't see any effects on birth outcomes, or negative effects on birth outcomes. So birth weight and low birth weight were not expressly incentivized, but we don't see any negative effects on them. In Zimbabwe, we see it looks like a positive effect on quality and quantity of non-incentivized services without changes in process quality. We do that based on administrative trends. And the authors there, Jed Friedman and others, use some fairly innovative methods to try to get at this, and they see that there's no effect on acute respiratory infection, on diarrhea, on skin disease, or on diabetes. In the Democratic Republic of Congo, from Gil Shapira, we see that there's not an effect on quality of care. So again, this would be the inframarginal effect, despite an increase in the provision of preventive sessions for targeted services. So no negative effects there on quality of care. As we carry this forward, we do some additional analysis here on Afghanistan and Rwanda, and we do this in reduced form estimation, again, to try to cut through all the different pathways that RBF could be working through the health system. So it's useful to go over, again, just briefly, what is and what is not incentivized. The incentivized pieces in Afghanistan were around antenatal care, skilled birth attendance, postnatal care, vaccines, tuberculosis, and contraceptive prevalence rate. There was also a quality component around the equity of institutional delivery and equity of children's utilization of outpatient services. And there was also a balanced scorecard that covered quality of services. In Rwanda, the incentivized services were growth monitoring, antenatal care, facility delivery, family planning, consultations, and new users. And there was a quality component on completion of quarterly reports. This is for the second impact evaluation, or the second RBF program, the demand side. And here we see, again, a whole lot of null effects all over the place. So this is for Afghanistan and Rwanda for the extra-marginal outcomes, where we would be worried about the effect of incentivizing some but not other services. We see that across the board, there's really not a lot in terms of negative effects. There is one, and that one, I should say that we estimate this both for the overall population and on the wealth aspects of equity, seeing if the bottom half of the distribution is negatively affected. We don't see anything there either. There is something going on with, excuse me, with tetanus for pregnancy in Afghanistan, and that effect does survive multiple hypothesis testing. We're not quite sure what's going on there, except to note that there were some implementation challenges in Afghanistan. But this is one of many, and we'll see in Rwanda where we can look at the inframarginal effects in satisfaction and cleanliness. There is again, there are null effects all across the board. There's really nothing much going on. So, taken with a pinch of salt, we can sort of conclude that for ANC quality or inframarginal effects, there doesn't really appear to be a differential spillover effect for Rwanda and Afghanistan overall, apart from the one that I noted on tetanus for some reason. There are some positive effects in some other pieces of the study that we did, but there's mostly no results all over. In terms of extramarginal effects with client, actually I think I had these reversed. The ANC quality, or whatever, it doesn't matter. But there are a lot of null results here again. The interventions appear to have very few negative crowding out effects. These effects are generally equity neutral. There is early evidence that these systems are operating within the production possibility frontier, so they are not yet productively efficient. As such, RBF will not necessarily, it may, but it does not necessarily cause substitution away from non-incentivized outcomes or from quality of incentivized outcomes. So, wrapping up, lessons and implications thus far. RBF programs aren't easy to implement. So this is more from the implementation side, the design side. They're not easy to implement. They're not easy to understand. We certainly saw some challenges with the Afghanistan program, where going back and talking about the program with service providers in Afghanistan, it was clear that they didn't really understand how the whole program worked. And so there's a lot of work that has to be done in communicating to providers how the incentives work, how the new structure will work. And again, it is a fairly complex reform, and it takes a lot of pieces that need to be moving in order to make it go. We also saw that because of that complexity, that having an ability to observe how things are working, having built-in process evaluating mechanisms is critical for being able to make a PBF program work, because that then allows for mid-course corrections and understanding what are the bottlenecks along the implementation process. So we also see that demand-side and supply-side incentives really tend to work on different margins. And because of that, because they seem to be kind of largely orthogonal, that they may work best when combined. So in Rwanda, for example, we see we see the first study that is more supply side, the second study that is more demand side. Neither of them sees a lot of effect. So the supply side doesn't see a lot of demand side type of effects. The demand side intervention doesn't see a lot of supply side effects. But the supplies that together, we might be able to get more from each of them. And this may be especially true for making equity improvements. So we can make equity improvements in coverage of services, but in terms of coverage of population, it might really take improving incentives on the demand side to get the poorer populations more willing to come in and benefit from the increase in service coverage. In terms of design of payments, there are some serious considerations. So we see that uncompensated price reductions can reduce motivation and effort. We saw that in the DRC and the Haut-Katanga pilot. We see that team incentives play a positive role, and that was interesting to know that there is a social dynamic within teams. But that too low of an incentive can lead to an inadequate nudge to provider behavior. So you do need some sizable incentive to get providers to move. And yet, incentives can't be unsustainably priced. And so there's a trade-off there. And we are concerned as within the HRITE program with all these pilots and trying to understand the sustainability of results-based financing. So that is true unless you expressly state to your providers that the incentive is going to be temporary, in which case you can still get lasting effects that go even after that temporary incentive is removed. We see that if coverage indicators are high, the target or coverage-based performance incentive frameworks might be better suited than a fee-for-service framework. And finally, we see that equity improvements may need strong targets to actually improve equity. As in Afghanistan, we saw that there were actually equity targets. They were weak and not well understood, and we saw that there were improvements in skilled birth attendance in equity, which was an equity-targeted outcome, but there were not improvements in antenatal care, which was another equity-targeted improvement. So the big takeaways on results. At the end of the day, what do we learn? With all of the appropriate caveats on heterogeneity in design and in context, we see that overall RBF can successfully improve coverage and quality indicators in a really wide range of contexts. This is encouraging. However, it's important to note that RBF is not a silver bullet. It has not improved all outcomes everywhere. But that's kind of not surprising in a portfolio as large and varied as this, that you would see some things that actually don't improve. Now, we are planning, and in fact are currently in the process of doing a meta-analysis to bring all of these results together, both from the bank and from non-World Bank projects, both from the demand side and from the supply side, to try to understand what the overall effects might be. On unintended consequences, we see that these are largely neutral, but that we should proceed with caution. So on equity, for example, equity might be difficult to achieve through supply side, except through geographic targeting. And there is limited, but some, evidence of crowding out of unincentivized services. So overall, for spillovers and for equity, we sort of see that RBF doesn't necessarily have negative effects, but be cautious and careful and be aware, because it may for some individual particular outcomes. RBF approaches can be cost-effective. We did present this result here, but we've had 3 cost-effectiveness analyses, actually now 4, and all 4 of them demonstrate that RBF is not only effective overall, but it is also cost-effective in increasing utilization and quality of care, despite the fact that it does have higher costs for verification. And again, we're only a third of the way through this stream of impact evaluation results. There will be many, many more to come. These results then should be interpreted, so the results that I've shared today should be interpreted as instructive, but certainly not conclusive. And I would say that same thing with each of the additional individual impact evaluations that comes through in this stream or anywhere else, that individual piece is instructive, but it should not be seen as conclusive. There is a large remaining learning agenda. In fact, we've just gone through revising the learning strategy for the Health Results Innovation Trust Fund. You can find that on the website at www.rbfhealth.org. But as today is UHC Day, Universal Health Coverage Day, it's useful maybe to think about a few implications for RBF on UHC. Of the three dimensions of UHC, of coverage in services, coverage in people, and coverage in costs, RBF has demonstrated an ability overall fairly robust to improve coverage of services, but not necessarily coverage of people. Coverage of costs, except for in the Zimbabwe case, has really yet to be explored. It is important to note that in Zimbabwe we do see a reduction in out-of-pocket payments. So there does seem to be a role for RBF in feeding into a UHC goal or a UHC design. It's a useful component to improve strategic purchasing and autonomy, but it should certainly not be seen as a replacement for the health system, certainly should not be designed or implemented in isolation. There are a couple of questions now that remain, and I'm not sure that these questions will be answerable by the Health Results Innovation Trust Fund, as again, all of the HRITE projects have been implemented, all the baselines have been collected, the impact evaluation, the impact evaluations have already been designed. But moving forward as a broader community, we need to try to understand how can we leverage PBF and design its payment methods to improve strategic purchasing, and how can we link PBF strategies or approaches and strategic purchasing to other health system elements and reforms, whether it's in human resources or strategic purchasing of commodities or quality of care. I will end there. You've been very patient. Thank you all for your attention. It's been great to be with you. We have questions. Any questions? Let me see if I can go to the chat and see if there's anything there. So there's a question coming in on the how long of a time period was the study conducted over? So the individual impact evaluations usually cover a time period or an exposure period of about 3 years or so. This portfolio, we got the first impact evaluations on this portfolio coming in about 3 years ago, maybe 4. So we've been sort of ramping up slowly. The HRITE program implemented slowly at first, and then increased in speed and number towards the end. We should expect the remaining 16 or so impact evaluations. We should have those completed and to us within the next 2 to 3 years. So this is going to be a very exciting time in understanding the effects of results-based financing globally overall. And this is really an exciting opportunity. It's very rare that we have such a very high-level, rich, well-identified set of impacts across such a wide range of contexts, with a somewhat homogeneous implementer and structure. We have a couple more questions coming in. And I think we're supposed to end at the hour, at 9 o'clock Eastern time. So a question coming in from a listener. Can you expand on your comments regarding the cost effectiveness analyses of results-based financing? What were the higher costs mentioned? So principally, the higher costs are higher verification costs. In order for results-based financing to really go, so remember, we are paying providers to deliver, or according to the number of services that they deliver, or according to the quality of services that they deliver. That payment happens through the administrative data portals. They report how many services they delivered, but because that's just self-reported, there needs to be some sort of a verification process. And that verification process can be the expenses there are non-negligible. And so that means that the overall cost of the program can increase. It's important to note, though, that when in doing these cost-benefit analyses, that sometimes I've seen some cost-benefit analyses done outside of the bank that are done in a way that, to my mind, doesn't seem accurate, where they compare the total cost of results-based financing to the marginal cost of business as usual, and that's not usually how you want to do it, because oftentimes the results-based financing is supporting the general health system. And so where it is, the costs on both sides of that ledger for the general health system, those should net out. And so if you're just looking at the RBF specific costs, then as one should, then you do see that RBF tends to be cost effective. There's a question on linking increased availability of equipment to decisions by facilities to use RBF to purchase needed inputs. And I would say that yes, indeed, we do see that. We see that both in the impact evaluations. So I believe it was Zimbabwe and Zambia, where we see an increase in the availability of equipment for both of those cases. Those are the two that measured that outcome. I should note here perhaps that it may look in that first section when we were covering the effects, it looked like it might have looked like I was sort of skipping around and sort of selectively reporting on different outcomes. That is driven, at least in part, by the fact that not all of the impact evaluations are examining or assessing the impact of all of the same outcomes. But for Zambia and Zimbabwe, those do look at the availability of equipment, and we see that the availability of equipment does increase in those two contexts. We then pair that with some qualitative research, where we go and we ask, what did you actually use the PBF money for? And indeed, they told us we used it for, among other things, for purchasing equipment. The questioner follows up with, but is this equipment provided another way? Do we know what the facilities that the facilities are purchasing equipment directly? So it is possible that they could be provided another way, but remember that we're doing this in a randomized controlled trial. And so if there is another way being provided to one group, it would also be provided to the other group. So in other words, anything that is happening external to the HRITF scheme here should be affecting both the treatment and the control areas equally. And so if there is, for example, if there is an NGO or another, say a bilateral that is providing equipment, that equipment would, in expectation, be provided equally to both the treatment and the control group. And so that effect should net out. So where we're seeing that there is actually an increase in payment, or sorry, an increase in equipment availability, we can isolate the cause of that increase in equipment availability to the performance-based financing because of the identification strategy that we have with the impact evaluation. And then that followed up with the qualitative research that we did with the health service providers, asking what they're doing it. So Rena Eichler is continue on, indicating not necessarily there is often extra investment in PBF areas. In one country that I know, if availability is a precondition of participating, and extra funds are provided for investment. So again, it comes down to the identification strategy. So certainly, well, I suppose Rena, that this would be on a case-by-case basis, right? So certainly there can be some contexts where there is performance-based financing that is also coupled with additional purchasing or just large additional funding, direct purchasing from the central government to these areas. That is certainly possible depending on the scheme of the overall project. But in the projects that we're talking about here, overall, we are talking about projects where we're being very, very careful to identify the effect of PBF. And so the general things that are coming out of the central government or from any other entity would be delivered to both the PBF area and to the control area in a carefully managed way. And so for that reason, at least for these evaluations that I'm discussing here, where the World Bank has more influence on how the central government is spending that money and what they're doing with it, we feel more confident that we really are identifying the effect of PBF as PBF. Any further questions? Well, hearing none, I don't know if Virginia is still on to wrap up, or Nicole.
I am. Thank you very much, Jeff. That was a great session, and I think that there's probably going to be, I don't know about everyone else, but it's often after the webinar that I start to think through some of the issues more deeply and have some questions. So if there were the opportunity, maybe people could potentially follow up with you after. But thanks again for your time, and thank you also to everyone who's joined us today or this evening, depending on where you are. I think this has been a really appropriate presentation for UHC Day, and thanks again to everybody, and good evening.
Great, thanks, Virginia. If people want to follow up with me individually, my email address is jtanner, JTANNER, @worldbank.org, and I'd be happy to have a follow-up conversation. Thank you. Great to be with you.
Thank you, Jeffrey.